Thank you, Sue, for that wonderful introduction, and thank you for inviting me to come and talk to the examination of the newborn and the education of the parents. Before I start I need to begin by stating what I mean by the systematic examination, because I think terminology is interchangeable. First, you mentioned NIPE, and NIPE is a screening for only 4 areas, which I was part, along with developing the examination of the newborn, I was also part of the development of NIPE. And when we developed NIPE, we were very, very clear that it was a screening for heart, tested, hips, and eyes, only those 4 areas. However, as you said, the NMC standards now have asked us to review the baby as part of our everyday practice, and that is stated within the NMC standards as the systematic assessment of the newborn. The NMC standards, unlike the NIPE, which is a one-off assessment, the NMC standards talk to the examination of the baby on the continuum from birth to 6 weeks of life. The NMC standards also ask us to look at the baby both from a social, psychological, and educational point of view. Our role is to review the history, which we're going to talk about within the next half an hour, and identify clinical risks, stroke red flags. I'm never quite sure. We always change the words, but I think now is red flags. And then go forward after we identify the clinical risk and go forward and assess the baby from head to toe. That head to toe assessment, which was deemed as a systematic assessment of the newborn, includes the NIPE screening. So NIPE screening doesn't stand on its own, it's part of the systematic assessment. Following that systematic assessment from top to toe, including NIPE, we then come to a conclusion as to what is the outcome. Is there any immediate care the baby requires? And then we go forward to the continued plan of care to follow that baby through. We next need to consider the fact that we now need to consider the baby after he's been examined. What does that examination consist of, which I'm going to come to? And some people, there is a confusion that this systematic examination of the newborn is a discharge examination. And yes, to some degree, to a lot of babies who will be going home within the hour, it is a discharge examination. However, for the majority of babies who are going to go home 2 or 3 or 4 hours later or the following day, the baby needs to be reviewed again by the midwife, as you see on this slide, who will be sending the parents home before the baby goes home. It's important to hear that and listen, because we can't just send the baby home. I was part of the chair along with Janet Redding that looked at jaundice, and the babies who developed kernicterus were babies who were seen in the clinic, what we would call with a systematic examination from head to toe. That babies then went home in the afternoon, but nobody actually reviewed that baby again, although the mother said when she was questioned, the baby did look yellow in the afternoon when it wasn't yellow in the morning. So it's very important that we follow the reports that are given and work with them. And that means within the hour, yes, it can be seen as the baby going home. That's adequate. But more than an hour, we need to review the baby again. Now we come to language again. And the language we use for babies going home has changed since NICE guidelines. We used to talk to the mother and baby being discharged to the community. The word that NICE guidelines now talk to is that we are transferring the baby from hospital to the community. So the word that I'm going to be using throughout this presentation from the baby going from hospital to the community is transfer. Now, when do we transfer babies to home? Well, we transfer the babies to home, of course, as we all know, when the baby's well enough. But apart from the baby being well enough, we also need to recognize, and as I'm going to be talking through, how much information does the mother have in order to support the care of that baby and make sure that the environment at home is as safe as the one in hospital. And if it's a second baby, lots of mothers have much information and they can teach me and you quite a few things. If it's her first baby, though, she's brand new to this baby, brand new to the knowledge of what this baby can and can't do. And although they're very keen to go home, once that baby's home, they need the knowledge to make them feel safe and confident in the care that they have. And that empowerment includes the information we share with them. When should that information information begin? Well, hopefully we should begin this information in the antenatal period, because as I go through this presentation, and I won't have time to cover everything, there's a huge amount of information that we need to provide to the mother and relevant others. And to actually bombard her with a lot of information while she's in the hospital, in the short time she is, she will absorb some, but not all. So we need to consider ways, and maybe some of you have already got excellent ways to share that information. I used to make sure, and I still do, that we make the information in short spaces throughout each visit to make sure the mother, when she hears the information again in the second time, it is the second time she's hearing it. Giving it to her in the antenatal period, it also gives her time to consider that information, go on the web, discuss the choices she has with relevant others, so she feels prepared when she comes into labor. It's very important that we undertake and recognize a very important part of the assessment of the newborn and the systematic assessment of the newborn. The foundation to that assessment is the history. And truly that history, without that history, that examination is not very safe. It's important, and for the students who are on this course, and I know quite a few of you are, that you do spend the time to take the history, and that we as midwives give you the time to do that before you actually get to examine that baby, because the history will guide you as to what care that baby will require. It's important to also recognize, in order to get the true history, we need to provide the mother with the right environment to give her confidentiality and safety to give that information. And I don't know about outside London, but inside London, we have a lot of dialects, and it's to use the different available lines, language lines and interpreters we have to our service to help us speak to the parents, because without education, that baby and that mother will not be as safe as they could be. It's also important to think of the language you use and to keep talking to a father and not partner, because the father and partner may be two different people. Normality, well, we can have a whole day discussing normality, but the important thing I'm trying to get across here is the fact that this baby in utero didn't have anything to do for himself except swim away in Lycor. And once he's catapulted into the postnatal world, he now has to adapt and do everything for itself. But that doesn't happen within the first few minutes of life or the first hour. It takes hours, days. In fact, it takes 48 hours plus for that baby to transition to postnatal life. Unfortunately, we don't have sort of a looking glass into the baby to know that he's actually transitioned. So we know the most major transitions can take up to 10 days. So therefore, it's important to recognize that each assessment we undertake on this baby, including whether you want to call it NIPE or the systematic examination, it only assesses that baby for that moment in time. That is valuable information for the mother to have, to be empowered to consider the fact that if after I've examined her baby, and I make sure I say that to her, the baby within an hour or a day or so doesn't look so well, not to think, oh God, I'm an inexperienced mother, it must be me, I must be the one that, my baby's probably all right. Stephanie said the baby was okay, so it must be. No, we need to empower her to recognize the earlier she tells us of any concerns, the quicker we can act and minimize harm to that baby. We now need to consider the episodes in which we examine babies, and I'm missing one, which I would talk to in a minute. We examine babies at birth, and then we examine the babies at 1 hour. Hopefully every baby gets that 1 hour, because we need that baby to have that uninterrupted hour with his mother. And then we're going forward from that 1 hour assessment, producing a care plan of what we would like that baby to be seen. Some babies will require to be seen 3 hourly, 6 hourly, whatever that time interval is between that first birth assessment to the follow-up. When it gets to the 72 hours, the baby will require to undertake what we all know as systematic assessment of the newborn, which includes the NIPE. Now, it says 72 hours, but I wonder how many of us examine the baby close to 72 hours, because most of the babies that I examine in London are going home in far less than 24 hours. So they're really only just beginning the transition. So education to the mother is vital. Then depending on what time, I transfer the baby back to the ward midwife, who would then transfer the baby to the community. Now in the community, the baby will then be examined at regular intervals. I'll put those episodes up because sometimes my student midwives think they've been trained just to undertake that systematic examination within the 72 hours. No, we are there to continually support that baby from the birth to every visit that we actually undertake. So please take time to learn from each care episode that you provide to that baby. What information does the mother require? Well, she requires quite a bit, but I've put some of the main points here. And if I haven't covered everything you want to know, please add them in the chat and I will do my best to answer them at the end of this discussion. Then she needs to know that we'll be undertaking the ABGAR score, and we'll be doing that, making sure that the environment is nice and warm, whether it's home or hospital. And she also needs to be asked and consent as to when we actually clamp the cord. When we clamp the cord, on the whole, the majority of babies will be perfectly normal and will be great to give them at least 3 minutes before clamping the cord. However, if it's an infant of a diabetic mother or a baby that's intrauterine growth restricted or other babies, while I'm doing the ABGAR score within 1 minute and I'm assessing and drying the baby, if I recognize when that lovely baby is crying like this one above at that first picture, and it goes beetroot red, I recognize that he's polycythemic and will not benefit for any extra blood, and I will clamp the cord early as quickly as I can. Now, I can't be doing that if I haven't actually discussed this with the mother earlier, and hopefully I will make time to do that. I must do that. Otherwise, the mother would think that I'm not following her birth plan. Then we also need to be thinking about how we reduce the stress of the mother regarding resuscitation. And resuscitation equipment and an area for resuscitation needs to be undertaken both if it's at home or hospital. And we need to tell the mother the basics of the resuscitation process and what it would involve and explain the equipment. Give her the confidence to know. And I have to tell you, throughout my years of experience over the 30 plus, that the mothers get very stressed, but they feel confident, and that stress is reduced if they know the practitioners who are helping their baby know what they're doing. We do the same if we have a relative in hospital. Once we feel confident in the doctors and nurses, we are much more or less stressed than if we didn't. The other big area to consider straight after birth is what you see on my second picture, that lovely skin-to-skin care that baby's receiving with his mother and father. And hopefully there's a midwife, and should be a midwife in the background, to make sure that it is safe skin-to-skin care. And that comes from the guidelines given to us by BAPAM. And I'm sure many people on this call are aware of them. If not, please look at them. You will be given a resource sheet that gives you all the websites and the evidence that I've used for my talk. And it's important to be aware of that because we need to make sure that we share that information with the parents. And the main thing I try and do with everything that I teach is not to scare the parents into not doing something that is so beneficial to the baby. And skin to skin is both to mother and baby. So I need to provide the information in a way that will support the baby and also support the mother to make the right decision. And that's to say to her, and if you give her information in a way that she can visualize what could happen, she's much more likely to follow. And the way I describe the safe skin-to-skin care, one of the things I get across to the mother is the fact that the baby's airway is very different to the one of the adult. The baby's airway gets narrower at the upper airway. So what I normally say to her is, imagine your baby's airway as a big straw. And as the baby takes air through his nose, as long as the straw is straight, the baby will get all the air into his lungs. If the baby's chin goes towards his chest, that straw will bend over, and therefore very little, if any, air would get into those babies' lungs. So it's very important that you do not use your mobile phone. You do not take your baby's eyes off that baby and continually observe. And that's why the BAPAM guidelines have asked us to continually observe the baby while he's having skin-to-skin care. Now, when you read those guidelines, you will recognize it's not just skin-to-skin care that causes postnatal collapse and babies having to be resuscitated. There are many other things, but they do highlight skin-to-skin care. The other issue that the mother needs to have, and I'm sure we all do, is the discussion on vitamin K. And I'm always asked, and when I teach the examination of the newborn, I'm always asked, what is true informed consent? And true informed consent isn't, do you like to have vitamin K orally or IM? Of course, that's a question to be asked. But before we get to that point, we need to make sure we understand what is vitamin K deficiency, early, classic, and late. And I would know what mothers will be at risk of early because of the history that I have, and will take appropriate action to give it appropriately and monitor that baby. And also with classic, and also recognize that the late is also a huge problem because the late will bleed into the poor baby's brain as well as his abdomen. So it's vital that the mother understands vitamin K deficiency and how to monitor her baby for her to give informed consent. Now, when I say which preparation, I mean, do I recognize which drug, which vitamin K does my trust provide? Is it vitamin K preparation that has the beef extract in it, or is it the vegetarian one? Now, if it's the vegetarian one, there's no need to be concerned as to whether the mother has special needs, special dietary needs. But if it doesn't, and if we're using the beef extract, we need to make sure that if she is a vegetarian, we need to make sure that preparation is available to give to her baby when the baby's born. Then we come to discussing, when does the baby have his first feed? And that seems to be something we will be discussing with the mother. That's a given. Now, the first feed, if the mother's breastfeeding, can be as soon as the mother feels comfortable to do so and that the baby's ready. That's at any time. However, if the baby is to be artificially fed, we need to take into consideration several things. One being, is the baby able to take the artificial feed? And I'm not being judgmental or against artificial feed. I'm very much in supporting mother in whatever decision she wishes to make and make sure she's successful in both to enable that baby to have a safe outcome. With artificial feeding, though, I need to know quite a bit, and I haven't got the time to go through it now. But the main points to go through is, number one, I need to make sure that that baby has no signs of respiratory distress and is alert and ready to take that feed. Not only that, but I need to make sure prior to giving that baby the feed that the baby's GI tract is intact. What do I mean by that? Does the baby have a cleft palate? Did I note that in the notes that the baby had polyhydramnios, or when I ruptured the membrane, was I swimming in liquor? If that was the case, I know that I can't give the baby artificial feed until I pass a nasogastric tube and get it x-rayed, depending on my hospital policy. And then I would give the baby artificially feed. But I haven't finished. I need to also make sure something that is happening that shouldn't happen. Babies are going home with an anus that is not patent. We need to make sure from the mouth to anus, the GI tract is patent and can take the milk. Second is another very important point that the mother should be told, and that is that babies do not use the breast just for food any more than they use the bottle just to get the milk. They use sucking to support them to get over the discomfort and pain following birth. So they will suck, and as long as they're breastfeeding, they cannot overfeed, and they will take it to their own speed. It's the best way, and we know that, and I don't have to teach you that. However, that's the same with a bottle. If you give the baby a full bottle, sometimes that baby, because it's so much discomfort and pain, he will actually finish half the bottle, not because he's hungry, but because he's trying to relieve the pain. So it's very, very important that I actually teach the mother not to give the baby more than about 10 to 15 mils in the first day at every feed of 3 to 4 hours. Another important part of examination of the newborn that I've learned some years ago when I met President, I don't know how many of you have read his work, and he's an amazing pediatrician. He's done an amazing amount of research on maternal-infant interaction and the behavior of the baby. And he talks to making sure that we understand the behavior in order to work with the baby in partnership. For example, he talks to the fact that if the baby is in deep sleep or light sleep, we should not be touching that baby. We should be leaving it alone and gently wake the baby up to sleep state 3 before we do anything with it. And that information needs to be given to the mother as well to successfully breastfeed. Because if we tell that mother that that baby needs to feed 3 hourly, she will go up to a baby in deep sleep, pick it up and try and put it to the breast. And if she does that, we know because we've been there, done that, the baby will start to cry within a very short space of time. And she thinks she can't breastfeed her baby when in actual fact, we haven't taught her how to understand the behavior of her newborn baby. An experienced mother will know that. An inexperienced one need to be taught. And I've got a short video to show you how to recognize the baby from deep sleep and how to gently wake the baby up from deep sleep. Before I put the video on, can I just share with you the wonderful way that this baby's wrapped? It allows that baby to be cocooned with the warm air that he produces around him rather than be swaddled, and he's got his feet at the end of the bed. Now, the first thing I would do up to any baby is observe how he's in his cot. And before I leave the baby after the examination, I will put him back in the cot and make the cot, as you see here, to show the mother how to support her baby, both with his breathing and with his hip development. This is the best way to have the baby. Now, going up to a baby before we actually touch, everyone here on this call who is experienced in the examination of the newborn will know the observation is very, very important. Sometimes more important than palpation and auscultation. It would give us an awful lot of information. So it's important to look to see what sleep state the baby is in. And if, like this baby at this moment in time, the baby's in sleep state,
begin by counting the respiratory rate in the...
You would see that the baby, can you see? The baby's waking up and moving, as you can see. Now, when we want to count the respiratory rate, it's important to get a baseline on what's normal. And that means that we do it without touching the baby. At this moment is a good time to do it before you touch and try and move the baby to a table or resuscitate to examine. And to also make sure the mother's watching you, because what you're going to be doing in a short while when I'm going to be speaking is showing her how to monitor the baby's breathing for when we ask her to do something a little later on. And to teach her where to look for the breathing and to make sure she understands is the abdominal area and diaphragm, not the upper chest that she needs to look at. In the same way that we need to teach our students to do that. We shouldn't be using a stethoscope or putting our hand on the baby to get the baby to give us a respiratory rate. We need to do it with an untouched method. Okay, let's go to the next one. And this is the next, sorry, just my computer's playing up. Okay, so we're now to systematic examination of the newborn, which hopefully would have given that information to the mother antenatally, so she's had time to look, plus the night screening that would be included within it, so she knows what we're actually doing. She would know that we're going to be examining the baby from head to toe and why we want to do it. Why do we want to examine her baby or every baby? And the main things that I concentrate on giving more information on are the things that I've found over the years the mother finds difficult watching. And that's the examination of the mouth. As you know, we don't just digitally examine the mouth now. We also need to use the spatula to review the soft palate. Now, putting a spatula into the baby's mouth when he's moving is not going to be very safe. So I need her support to hold the baby's head while I insert the spatula and look to the back of the baby's throat. So I needed to recognize the importance of that assessment and how she can help me. I also need her to understand why I'm examining both her female and male genitalia, including the examination of the testes. And then I also need to explain about the hips. Now, the hips is an issue because where the other two are not really uncomfortable for the baby, hips can be. If you're inexperienced, and it takes some time to get to the hips, because to do the hips, we're examining the baby from head to toe, we're turning the baby over, examining the spine, and then going to the hips. But then if we're taking quite some time, more up to about 15 minutes to do so, that baby will start to object, and the mother will start feeling uncomfortable if her baby's crying, and she thinks the baby's in pain. She needs to recognize that the baby isn't in pain. In fact, he shouldn't be in pain. If he is, we're not doing it correctly. It's, if you do it within 5-10 minutes, most babies would not mind, but some babies would. And she needs to understand the importance of the hip assessment. Not only does she need to understand this assessment, but also recognize it's vital that that baby gets the follow-up at 6 to 8 weeks to make sure that the baby hasn't developed a problem in the meantime. Another big area that people who know me on this call would recognize is the importance of the one-to-one communication with the baby. Now, I always say to the mother that I will speak to her before and after I finish the physical assessment, but during the physical assessment, I'm going to give my 110% concentration on that baby, because that baby's speaking to me throughout the physical assessment, and I don't want to miss a single word that he's saying, because it will help me identify any problem she or he may have. For example, look at this lovely baby on this slide. I mean, the babies we examine are so privileged and they're so lovely. They're amazing. Look at this one. He's telling me already that he's well. The video isn't on, but I can tell you that he has no respiratory distress. He's warm. He's giving me beautiful eye-to-eye contact. He's almost hypnotized. I'm hypnotized with him. And I could see that his eyes are clear. And even more importantly, even more amazing, this is a newborn baby less than 24 hours. He's identified where his mouth is, and he's recognized by sucking his finger, he will feel less discomfort. So he's going ahead and sucking his finger and consoling himself. How wonderful is that? You need to share your amazement of this baby with the mother, and she can carry on feeling less scared of this brand new baby. We need to concentrate and consider reviewing these babies and talking to the mother about successfully breastfeeding, and the importance of recognizing if the baby's well between the 9th and 91st centile, they should, if they're well, not require any top-ups. Sometimes the mother may think that the baby's crying and he needs more than what she can actually provide. You need to explain to her how glucose metabolism functions and how it's there for every baby for the first 2 days while her milk is coming in. And physiologically, the less the baby's getting in the first 48 hours, and the amount of colostrum that she's producing is perfect for her individual baby. And we shouldn't be encouraging her to have any top-ups just to satisfy our needs that this baby's getting something. Because the only time we should be giving any top-ups to any baby is if it's medically indicated. Otherwise, we are taking away the safety net that nature has provided for that specific baby. Then we need to think of jaundice. Now, as I said, jaundice is something we're getting better with and we recognize early. Sometimes, though, we need to also consider late. And I know all of us recognize that late is perfectly normal in a large number of babies. But again, going back to what I said before, a few babies will not be necessarily normal. And one of the things, there's a couple, but one of the things that we need to exclude if the baby continually is jaundiced after 14 days is biliary atresia. And that's the yellow alert that the second slide shows that you can find on the web as well. And that is picking them up early before they're 2 to 3 months of age, because if you delay picking that up, that baby will end up with having to require a liver transplant. And that's not an easy thing to have to do. So just be aware of what is early, what is late, and what information we need to share with the mother. Now we come back to cardiac changes. And if you remember, and if we all go back to understanding the hemoglobin, the fetal hemoglobin of a baby, we all should remember, and the students amongst you need to understand is, fetal hemoglobin makes the baby show cyanosis as a late sign. The baby can desaturate down to 75% and still look pink. So therefore, it's very, very important that you do not take cyanosis as your first sign and teach the mother one of the early signs. And one of the early signs goes back to that little video, is asking the mother to view her baby before she puts it on the breast or gives it a bottle, and look at how quickly the chest is moving up and down. Note that pattern. And then ask her, after she's finished feeding her baby and the baby's lying quietly, to monitor the speed of breathing again. And if that's a lot faster than before she started, you and I both know the baby's actually in respiratory acidosis and is trying to blow off the CO2 because of some problem, probably cardiac changes. So the quicker you catch that baby and do something, the better the long-term outcome. Cyanosis is an issue. And if you are looking at cyanosis, remember dark-skinned babies do not show you the cyanosis from the skin. You need to look inside their mouth, the gums, and preferably use a saturation monitor after you've done the cardiac assessment to give you a true indication of the baby's saturation. An infection is another big issue, and we need to be aware of that. Infection is very much of a problem for babies. They get infections of various types. They can be eyes, mouth, cord, and the one that we really are concerned about is group B. Now, group B, we all seen and are aware of as far as the early is concerned, and we can pick it up because they're all in hospital. And if the baby's going to have a problem, it will show within 6 hours to 24 hours. Now, any baby that's been treated or any mother that's been recognized to be group B positive needs to be given signs and symptoms of late group B streptococci, because that will attack the meninges. So some hospitals, I'm aware, and maybe some on the call, you would know that you give your little mother a little card and you need to explain what those signs and symptoms are. And we need to talk to the other infections as well. Education continues, and as you see, the list is growing. We need to be thinking of why to avoid swaddling the baby and how that affects the development of the hips, and how we can support the development of the hip by sleep time and playtime. And just remember, playtime means being prone, and we need to teach the mother the same way as we did with skin to skin, how to maintain a clear airway. She will need information. I'm sure you all been asked, when can I bath my baby? And remember the importance of where she is. If she's in a hard water area, preferably after 5 days. If she's got a softener in the house, she can bath the baby not less than 24 hours to allow the baby. Or if she lives in an area where the water is soft, anytime after 24 hours. The longer she leaves the baby without bathing, the better. Encourage them not to smoke, because that is a huge problem. Blood spot screening, we need her to understand that, because I need her to be aware that I'm coming to do it and to prepare by putting maybe an extra sock, because I don't have those lovely little heat pads, and maybe some of you do have them, and maybe you can share where you get them from, because they're wonderful in heating the baby's heel to make blood spot screening easier. Not only do I need to do the test, but I also need to explain to the mother the importance of when to receive the result. When I first did the blood spot screening, we used to call it a Guthrie then, I used to say to the mother, and I can hear myself saying this, no news is good news. Well, it's no longer the case, because we now know that those cards can get lost. And I thought that I've screened the baby, but maybe this baby has never been screened because that lab has not received the card. Even more importantly, that she gets the result is because if the baby is high risk and requires BCG vaccination, that baby will not be able to receive it because it's a live vaccine if it's positive to SCIDs. Now, the NICE guidelines talk to the Lullaby Trust Baby Check, and some of you are using that already, and hopefully we are going to all be using it, because it's a wonderful little teaching tool that parents can have. They can download it onto their phones, and I think it's in multi-language, and they can actually be asked 19 simple questions, and the yes or no answer will give a score. That score that you see on the right of your slide indicates whether that baby's well, or whether that baby requires to be seen by a doctor quite soon. Now, safeguarding was raised even more during the pandemic, as Sue said. And we had more babies admitted in A&E with safeguarding issues. But we need to prepare for all our parents. And if the mother's going home to lots of support, less of a problem, but still maybe give her that support, treat all the same. But if she's a single mom going home on her own, she's going to sometimes end with a baby that is her first baby, no knowledge, with the baby continually crying. She's had no sleep. She's more likely to find the whole process very stressful. And we need to minimize that by giving her the support guidance, the helplines that she could actually contact, including ourselves. But one of the other things that we can do during the systematic examination of the newborn is make sure that when we're reviewing the eyes, and remember, NIPE only looks for cataracts, we look for the systematic assessment for many things, including the subconjunctival hemorrhages. And we need to record both when they're present and very importantly, if they're not there, because it's quite normal physiological finding straight after birth, not when the baby's 10 days of age and you go in and you discover that baby has actually now developed one, because it means that he was probably shaken. Record keeping, why is that important? Because it supports continuity of care. Some of you on this call are very lucky to provide continuity of care teamwork, and that mother sees you and maybe one other person. But in my experience, both in hospital and the community, we have very few continuity teams, and hopefully with time, maybe we can increase that. But in the meantime, the support continuity of care for that baby is our records. The plan that we have put in after each visit will support the person that goes in after me. And it also means that the mother will have that information. So if I said to her, your baby is fine, but tomorrow I would like to come in and do a TCB, a test to see if your baby's jaundiced. If I don't arrive, she is my safety net to ring up and say, Stephanie, you were supposed to come in, why haven't you? Or if I'm not there, somebody else will be alerted to go in and support that baby's follow-up plan of care. And if we have any issues, we need to record them. To finish, we need to recognize that we have to take some takeaway messages, and maybe from your discussions, we can add to this list. We need to listen and act on the mother's concerns. Before I start on the systematic examination of the baby, I always say to the mother, can you tell me which area of the baby would you like me to focus in? Because she would be like a Sherlock Holmes with a magnifying glass, going through her baby like anything. And if there's anything wrong with that baby, that mother would know. And not only do I ask the question, but I listen to the answer and follow through and give her a reply to whether her concerns are valid or not. And I have to tell you, most of the time they're valid. We need to think about when we start education. Maybe consider doing workshops, not just on breastfeeding, but on neonatal care, and time them throughout antenatal. And if we don't do it antenatally, maybe we can have a workshop by the appropriate professional in the postnatal ward and give them 1 hour workshop before they go home. That would be very, very valuable. Share with the parents the websites. Feel confident and competent in the assessment of the newborn, because if I'm not confident or competent in that assessment, how do I teach my students? How do I teach the mother to take on board the information? Because it needs to be adapted to the individual for them to take on board the amount of information we are providing. We need to tell the mother not whether she would like one thing or another, but why. What does each action that I do, what does it mean for her baby? And what are her choices, true choices? And then go forward and make sure that we document and make sure that she understands who to actually contact if she does have any concerns. Thank you for listening.